Alright, up next, choledocholithiasis. Breaking this word down, choledocholithiasis, just like the last chapter, lithiasis stones, but instead of cholelithiasis, it's choledocho, meaning this is in the bile duct, not the gallbladder or the cystic duct, the common bile duct. We'll also go over cholangitis, so cholange, which is bile duct, and then itis, inflammation. Now, at face value, the bile in your body, in your patient's body, is sterile. This is before an intervention. However, that bile can become infected or contaminated depending on what's going on intraluminally. The pathophysiology of choledocholithiasis is that a stone gets stuck within the common bile duct somewhere along the way. Then, that continues and does not go away. And eventually, you start getting cholangiovenous reflux. That number is not very important to memorize. That reflux leads to bacteria, and then that can ultimately lead to cholangitis, with the most common offending agent, E. coli. Put this together: liver, common hepatic, and the cystic duct then becomes the common bile duct. Got your duodenum right here, stomach right there. For choledocholithiasis, the stone is getting stuck. This is definitive choledocholithiasis. Thereafter, with how much pressure this is causing on the wall of the biliary system, you start getting cholangiovenous reflux. And an anatomical point we should point out is that the blood supply usually comes in at 3 and 9 o'clock. Now, with that being said, you have arteries going to and then veins going away. But when you start having pressure on the wall, that's when you start getting that cholangiovenous reflux. And this isn't super high yield to memorize for tests and so forth, but it helps you conceptualize. What ends up happening then is that bile flow is not able to get out. It then starts racking up, and that's how you have increased bilirubin. But on top of that, the fact that you have stasis of the blood supply, that's when you start getting bacteria, and the bacteria eventually converts to a cholangitis. And again, the most common offending agent, E. coli. And how these patients present are typically in an acute situation. They're not going to be in your clinic. They're going to be more often than not in the ER or an acute care surgical setting. They may have fever, right upper quadrant pain, and jaundice, but this isn't just choledocholithiasis. You actually start getting concerned for cholangitis. Choledocholithiasis, a large amount of these are actually silent, but the ones that do present usually have jaundice and a little bit of right upper quadrant pain. When you start developing fever, and especially alterations in your cardiovascular status, as well as your neuro status, that's when you really start considering the conversion from choledocholithiasis into cholangitis. Why? Well, again, the stone just being present in the biliary system is choledocholithiasis. But when you start having buildup of bacteria and the concern for infection to the point of sepsis, that would indeed be cholangitis. Now, a couple of guys wanted to be remembered forever, I guess. So Charcot's triad and Reynolds' pentad. You can decide to memorize these if you want. Sometimes they're thrown out on board questions and so forth, but typically you can walk yourself through a mental gymnastic of saying, all right, well, this patient comes in, this is the right side, that's the left side, and they have a gallstone that's stuck in the common bile duct. And so your pathology is right here. You've already knocked out right upper quadrant pain. You already have the jaundice answer because your bilirubin is going to increase. And the fever itself is, well, that's because you start having the bacteria being built up. So if you understand the pathophysiology, this is my takeaway anyways, and a big purpose as to why I'm doing these types of lectures is I think we can understand things from a microscopic or a much smaller level, then take that into the esoteric realms as needed. Charcot's triad would be fever, right upper quadrant pain, and jaundice. Reynolds' pentad would be the addition of ultramental status and hypotension. Now, how would you go about diagnosing this? Well, I always think about this just like an oral board scenario, or if you're seeing a patient in clinic or the ER, you've already done your history and physical. Let's start working them up with labs. You can get a CBC and focus in on the white count, as well as get a CMP. And with that CMP, make sure you fractionate that bilirubin. The bilirubin can be conjugated or unconjugated. And I won't go into too much detail here. However, if you do not have bile flow going past that stone, you're going to actually have conjugated bilirubin being built up. Thus, again, you want to make sure you fractionate that bilirubin. After you've gotten your labs, now what you can start with is an ultrasound. However, a large amount of times you're going to wish that you had an MRCP, and sometimes that is the best way to work up this scenario. There is also criteria out there, such as the Tokyo guidelines of 2013 and 2018, and these will go through the specific diagnostic criteria for cholangitis. So, the Tokyo guidelines for acute cholangitis in 2018, number one was fever, number two, laboratory evidence such as elevated white count and or a CRP greater than 1. Number three, jaundice, which can also include a total bilirubin greater than 2. And there's other criteria within this, including abnormal liver enzymes, biliary dilatation, and evidence of the etiology on imaging. So let's say you've done your labs, you've gotten your imaging workup. Should you consider an ERCP? And my takeaway for this is you should consider an ERCP if there's cholangitis, if you have gallstone pancreatitis, or if you can't do a common bile duct exploration. What we're going to review right now is an ERCP versus MRCP. And I'll state that when you're in a tertiary care or quaternary care hospital, GI is going to want to get those MRCPs to show that they don't need to do an ERCP. But the case in point as to why I mention this is that MRCPs are not therapeutic. MRCPs, for all intents and purposes, equals MRI. So, what is an ERCP? This stands for endoscopic, retrograde, cholangiopancreatography. This is basically a super advanced EGD whereby you're going into the esophagus, going into the stomach with a scope, going all the way down to the sphincter of Oddi. And now this isn't a typical EGD, whereby with an EGD you have lights, camera, and a working channel at the end of your scope. Instead, what you have is a side viewing duodenoscope. So your lights, your camera, these are all facing the side or side viewing duodenoscope. So what you're seeing right here in the diagram is a scope going down, and this is anterograde, right? However, you're then going retrograde up the biliary system. And now, since you're going retrograde into the biliary system, you're actually going into the cholangiopancreatic system, meaning you're going through the pancreatic duct, the common bile duct, and thus, when you put all these words together, endoscopic, retrograde, cholangiopancreatography, you can keep in mind that this is an ERCP. The big point here is that ERCPs can be both diagnostic and therapeutic, which MRIs or MRCPs cannot. So please do not confuse these with MRCPs. There are surgeons performing ERCPs out there, but again, by and large, these are performed by GI docs. Preoperatively, they may give them antibiotics. They're going to be giving this patient general endotracheal anesthesia. They're also going to be using, like I said, a side viewing duodenoscope. They'll start first with the patient in the left lateral position, and then they'll rotate the patient to prone once they're at the second portion of the duodenum, which then allows the shortest scope position to get that scope and the working advantage of that scope. A really quick side point that I just want to briefly go over. If someone has a Roux-en-Y history, they've had completely altered GI anatomy. Is that going to be an easy ERCP? I will adamantly say no, it is not. What you can do instead is a transgastric ERCP. This is going to be a combination between GI and surgery. So what you're seeing in this diagram right here is indeed a transgastric ERCP. What happens is you get access into the abdomen, make your incisions and so forth, blow this abdomen up with CO2, and then what you're doing is placing a port directly in to the stomach. Now, not the gastric pouch, not that small 30, 25 cc gastric pouch, but actually into that other remnant of the stomach. The port goes directly into this, and you'll probably use like a 15 millimeter port to be able to accommodate the ERCP. That ERCP goes through the port, which is inside the lumen of the stomach, thus transgastric, and then they're able to go all the way down to the sphincter of Oddi and do their work. All right, so getting back to the diagnostic workup. What we're seeing on the right side of this page is an ultrasound and then an MRI. As you can see, what's designated by this white arrow is an obstruction within the biliary tree. So you're seeing this biliary tree almost taper down, but there's an obstruction right here. That is diagnostic for choledocholithiasis. The MRCP, and again, different from an ERCP, an MRCP is an MRI. And so what you're seeing right here is the common bile duct stone, and multiple stones is what I would say. There's a bunch of stones kind of racked up right here. And you might have a whiff of contrast getting down into the duodenum because you're seeing just a little bit of contrast in there, so it's not completely obstructed. But I would say this is indeed definitive choledocholithiasis. So how would an ERCP look? An ERCP looks somewhat reminiscent of an intraoperative cholangiogram. You're still using moving X-ray or fluoroscopy. So right here, this is the side view and duodenoscope. And what you're seeing within this biliary tree, right here, you're actually seeing a meniscus sign. If you can remember from undergrad chemistry, you got your graduated cylinder, and we're looking for that meniscus or that bode effect of the water in that graduated cylinder. And that's what happens when you actually have a common bile duct stone. You can actually see a fair amount of times a meniscus sign. And then finally, an intraoperative cholangiogram, which we reviewed in the choledocholithiasis lecture. However, what you're seeing is traditional laparoscopy. You're seeing cholangiocatheter going in just like this. You have your common bile duct, you have your common hepatic duct, you have your cystic duct right here. And unfortunately, I would say this is a complete blockage of the biliary tree by a common bile duct stone, or again, choledocholithiasis. How would you address this? So, generally speaking, if you see a patient with choledocholithiasis, you're going to start them on IV fluids, make sure they're NPO, and before they leave that hospital, you're going to be planning on doing a cholecystectomy before discharge. If there's cholangitis concerned, 100% you should be giving antibiotics in addition to the NPO status IV fluids, and ultimately a cholecystectomy before discharge. What should you be doing prior to a cholecystectomy? Well, if you can, you wouldn't be planning on doing an ERCP. So let's say the ERCP is unsuccessful, and now the patient is refractory. What then? Well, then you can try a PTC. Let's review what a PTC is compared to a PCT. So a PTC stands for percutaneous transhepatic cholangiography. What this means is that you are getting percutaneous access. So right here you see the needle, the IR dock is right here, and they're performing the Seldinger technique. So they're going through the skin, percutaneous. They're also going through the liver, transhepatic, and they're accessing the biliary tree, so the cholangiography. Well, once they've accessed the biliary tree, they can use the Seldinger technique and maybe even upsize the catheter or be able to help decompress the biliary tree. A caveat here is that usually the IR team needs to have a dilated ductal target to be able to easily access these. So what about a PCT? So a PCT does not equal a PTC, even though they're a little bit close, aren't they? So a PTC is coming from up above, but a PCT is going directly into the gallbladder. So what a PCT stands for is a percutaneous cholecystostomy tube. Thus, it is within the gallbladder. The drawing that I have right here is that, again, you're going through the skin, so percutaneous, but you're not needing to go through the liver. However, there are certain approaches and certain times, especially if someone has non-alcoholic fatty liver disease or a large liver, that you will be going transhepatic to be able to get access into the gallbladder. Now, a large amount of times when you're considering doing a PCT is when you have a patient that is not healthy. Maybe they're coagulopathic, they're on dual antiplatelets, end-stage liver disease, etc., etc. How does the IR team perform a PCT? Well, they're going to be using ultrasonic or CT guidance to be able to get access directly into the gallbladder. Here are some images. So the yellow arrow is going to be the pigtail catheter. This red arrow is indicating the gallbladder itself. This blue arrow is going to be the cystic duct. Kind of difficult to see that, but it's right there. The orange arrows are the duodenum. The green arrow is the common bile duct. You're starting to put this all together, right? And this white arrow, I'm going to erase this. This white arrow, you're able to see that tapering right there. And that's due to the sphincter vodi. And then yet another picture of a percutaneous cholecystostomy tube. This is a patient that had a PCT placed, but at the 3-month mark, they underwent a tube study or a contrast study, meaning that they had this tube in place and they put contrast down and they were looking to see if that cystic duct was patent. And indeed, the cystic duct was patent. I won't spend too much time on the intraoperative technique for a PCT. However, it's important to keep in mind, regardless of if you're performing these PCTs or not, is the postoperative care. We may save this for another lecture to talk about it more. So, you have a patient that has choledocholithiasis, but how do you treat them? Well, we've mentioned the IV fluids, the cholecystectomy before discharge, ERCP if possible, PTC if possible, or is not successful, then you have to plan on operative cholangiography. But before we get to that point, a way that I like to look at this is by presentation. So, do you have a strong suspicion, a moderate suspicion, or a low suspicion for choledocholithiasis versus cholangitis? If you have a very strong suspicion for, let's say, choledocholithiasis to the point of cholangitis, 100% you need to be doing something, meaning an ERCP. If there's a stone present, if they have elevated bilirubin, especially greater than 3, or if their common bile duct is dilated, these are all indications that you should plan on doing something. And again, before that patient leaves the hospital, even if you have relieved those stones via an ERCP with a sphincterotomy or a balloon sweep, you still got to plan on the cholecystectomy. Let's say you have a low suspicion. Well, if you have a low suspicion, maybe they had a stone and it was passed. Their labs are normal, they have negative imaging and so forth. Well, in that case, just do the cholecystectomy because the next time the patient comes to the ER, they could have legitimate cholangitis. So let's say, well, you're kind of on the fence. It's not a strong suspicion, it's not a low suspicion, but more maybe it's more gray rather than black and white. Well, in that situation, you need to plan on imaging to help give yourself a better idea as to what's going on. How would you do this? An MRCP. So strong suspicion, do something, if ERCP if possible. A low suspicion, well, ultimately just get that gallbladder out. But for all of these, you should be planning on a cholecystectomy before discharge. So, moving on to other problems associated with choledocholithiasis. This is getting more into the weeds, more of the esoteric information, so you may just want to skip over this or end the video. But post cholecystectomy choledocholithiasis. What this implies is that you've had a gallbladder removed, but you're still getting gallstones formed. Now, this may be the situation where you want to designate this as primary duct stones. Now, the pathophysiology for these primary duct stones is usually biliary stasis and it's related to these specific types of stones. Everything else is essentially the same workup, treatment, and so forth like choledocholithiasis. The only difference is that in the vignette or when you see these patients in the ER, they've had a cholecystectomy in the past. All right, so a problem that's a little bit more common is a retained common bile duct stone, and this is usually a stone that's getting stuck after a cholecystectomy. So let's just quickly draw this out. So during a gallbladder surgery, you have gallstones, sometimes, right? Not all the time. But some of these gallstones can actually be stuck within the cystic duct. And if you go and transect this and pull the gallbladder out, there's still stones on that proximal aspect. And these stones can then fall into the common bile duct. And if they're large enough, they can even cause symptomatology. So it's just something to keep in mind from a surgical standpoint and how you'd be able to diagnose this or work this up as a cholangiogram. What about intrahepatic stones? Well, for intrahepatic stones, these are also a rare etiology, and typically this is due to biliary stasis and more commonly brown stones that then, off and on, can have recurrent pyogenic cholangitis. The case in point that I wanted to make here is that when you have stones that are stuck within the liver, the treatment for this would be a PTC, whereby you're accessing via Seldinger technique into the biliary tree, and then you're going to be planning to upsize these catheters to help extract these stones. If this all fails, then maybe you can consider a Roux-en-Y hepatico J, but that doesn't sound very fun. So, moving right along to impacted common bile duct stones, this is going to still be quite low yield, but you'll occasionally see this on a board scenario, but very rarely in real life. But what this means is that yes, you have choledocholithiasis, a stone is stuck, but it's not just stuck, it's very, very stuck. So you try to go in maybe with an ERCP from below, or maybe you try to go in with a common bile duct exploration transcystic or through the actual common bile duct itself, but you can't move this. So what do you do then? Well, in this situation, let's just say this is the duodenum right here, and this ends up going down to the jejunum, duodenum, jejunum. What you can plan on doing is making a longitudinal incision in the duodenum and then accessing where the sphincter of Oddi is at and performing a transduodenal sphincterotomy. And this would be done operatively, and I would say this has to be done open. But that's more of a treatment for a non-dilated biliary tree. But let's say they have a dilated biliary tree. What are the options then? Well, you can plan on maybe option A, doing a choledocho duodenostomy whereby you would take the duodenum and do a side to side anastomosis between the biliary duct and the duodenum, or Option B, a choledochojejunostomy. The benefit with a CJ over a CD would be not getting Sump syndrome. What is Sump syndrome? Glad you asked. It's somewhat of an esoteric topic. It is hard to find information on this, but I think it is interesting pathology. So, the pathophysiology of Sump syndrome is when you have choledochoduodenostomy, a side to side stoma, such as this right here. And what ends up happening is, well, you got some food and everything bypassing this, that you get accumulation of sludge and stones that starts piling up. And then eventually you're getting food refluxing into the biliary system. And then this leads to cholangitis. These people will typically have days to months of worsening symptoms, fevers, often on sepsis, and so forth. And what you're going to look at in the surgical history is, oh, they've had an HPV surgery in the past and they had a choledochoduodenostomy. And so, how would you work this up? You'd be planning on doing your basic labs, CMP, CBC, maybe get an ultrasound, but the go to for this would be a CT scan. And I wouldn't say an MRI would be a bad move, but in these situations, time may be of the essence, and so you want to get probably a CT scan. How you would treat this is, well, you would try to do an ERCP, whereby you're going down with a scope, a side viewing scope, as you might recall, you're going to be making a sphincterotomy to loosen up the muscle around here and then doing a balloon sweep, putting a balloon down here and inflating it and then pulling this out. If this is refractory, then you just got to go downstream for the duodenum to the jejunum and plan on doing a hepaticojejunostomy. So I want to spend just a little bit of time going over common bile duct explorations. Now, the best approach would be a transcystic common bile duct exploration. This can be done either minimally invasive, such as robotic or laparoscopic, or open. However, there are certain criteria that will not allow you to do a cystic duct or a transcystic duct common bile duct exploration. What are those reasonings? Well, number one is acute angulation of that cystic duct. You try to navigate around that, you're going to eventually avulse that duct or cause a lot of ripping and tearing. If you have stones more proximally in the common hepatic system, well, that's also an issue where you couldn't do a transcystic approach. And if you have a very short and friable duct, well, again, you have concern for ripping and tearing this. If you have very, very large stones distally in the common bile duct, wouldn't be able to dislodge that. You may cause more harm than good. And then taking multiple passes, up to like 8 to 10 stones, would be another reason not to do a transcystic approach. And here I have some other information listed on how you can do an open common bile duct exploration, as well as performing it laparoscopically, and then what to do postoperatively with the T-tube if you do use a T-tube in place. And in this diagram right here, a choledochotomy was created whereby the common bile duct exploration was performed.